Hello, my name is Stuart Connolly, and I'm here today with Dr. Jeff Healey, and we're going to discuss silent atrial fibrillation and the ARTESiA trial. This is an ongoing clinical trial that has already enrolled almost 1,000 patients, and we'd like to bring you up to date with some progress, but also to talk about the underlying rationale for why this study is important. Jeff, how are you today?
Very well, thanks, Stuart.
So Jeff, tell us why silent atrial fibrillation, also known as subclinical atrial fibrillation, is important.
So subclinical atrial fibrillation we now know to be very common in the pacemaker population. Somewhere between 30 and 50% of all patients who receive a pacemaker or defibrillator will develop this, and there's a lot we have yet to learn. Earlier studies like the ASSERT trial have shown that it is indeed associated with an increased risk of stroke. However, this risk of stroke is lower than we see with typical clinical forms of atrial fibrillation, so we need further data to determine if it's appropriate to treat this with oral anticoagulants or if one waits to see the development of more long-lasting atrial fibrillation.
Do we only see silent atrial fibrillation in pacemaker patients, or has it been seen in other populations?
So excellent question, and for which we have some recent answers. Large studies including ASSERT-2, the REVEAL-AF, and the PREDATE-AF trial have all shown that if you look in older individuals with cardiovascular risk factors, that you see a similar large proportion of these patients will also have atrial fibrillation detected with implantable subcutaneous monitors.
So if there's so much atrial fibrillation around, how come we never learned about it before?
So in the past, it was simply a matter of picking it up. Nowadays, with modern implantable monitors, with sophisticated dual-chamber pacemakers and defibrillators, we see a lot of arrhythmia that was otherwise undetected. So the early studies like Framingham and other large cohort studies simply didn't see this arrhythmia, and these patients were classified incorrectly as having no atrial fibrillation.
So silent atrial fibrillation is really something new that's been discovered because we have these devices that do long-term monitoring for us.
Absolutely, and we as clinicians have to resist the urge to simply treat this automatically as atrial fibrillation that we traditionally know, because I think it is very much a distinct condition, and recent guidelines have really highlighted this and said that we have a need for much more information in this area before we can make blanket statements about treatment.
So how is subclinical atrial fibrillation different from the usual forms of atrial fibrillation that we're used to treating?
Okay, so first of all, patients don't report symptoms. These episodes are typically short in duration, and they only are picked up with continuous long-term monitoring. And when we look at the studies like the ASSERT trial, like the TRENDS trial, the risk of stroke, although elevated with these episodes, is actually quite low in comparison to atrial fibrillation. And this is, of course, important because we are talking here about older individuals whose risk of bleeding complications with treatments like anticoagulation are higher. We have to then consider this low stroke risk when you're weighing the risk of treatment versus the risk of stroke.
So when do you think we should today treat a patient who's picked up with subclinical atrial fibrillation by his pacemaker?
So the recent guidelines, including those published by the European Heart Rhythm Association, say that we do need more data for this, and that the majority of patients where we detect atrial fibrillation, subclinical atrial fibrillation of short duration, there's no clear guidance on whether we should or should not treat. I think typically in clinic we all see some patients where we think our treatment is appropriate. When patients have a recent cardioembolic type stroke, we would typically intervene with an anticoagulant, and when patients have longer and longer episodes, we would also consider intervention. And a nice recent analysis from the ASSERT trial suggests that when episodes last more than 24 continuous hours, the risk of stroke does increase to the same level that we see with more typical clinical atrial fibrillation.
So the patient who's got a few minutes to a few hours of subclinical atrial fibrillation occurring, say, every once a month or so, what do we know about that patient? Should he be treated? Should he be anticoagulated?
Well, I think we honestly don't know if it is the right thing to treat that patient or simply wait until they develop longer lasting episodes. They do have an increased risk of stroke, but this risk is lower in absolute number, and these patients have a non-trivial risk of bleeding. So I think these are the perfect type of patients for the ARTESiA trial, where we are comparing the two strategies to see which is superior for this type of patient.
So subclinical atrial fibrillation detected by a device really is different from the usual garden variety atrial fibrillation that we see on 12-lead ECG. These patients are higher risk for bleeding than many of the atrial fibrillation patients we treat. So I guess that's the rationale for wanting to do a randomized trial of Apixaban versus aspirin.
Absolutely, and there's been several nice reviews written on this subject recently in nice journals like JAMA Cardiology, Circulation, and of course, as mentioned, the ERA guidelines, which have recently come out, summarizing very nicely the data on the topic. And I think it is very fair to say this is a different entity. We really do have to answer this question to know best how to treat our patients in pacemaker clinic, but also how to manage all these patients that we are now detecting with long-term continuous monitoring outside the pacemaker clinic. So very much right now is a problem for pacemaker and ICD patients, but of course with long-term implantable monitors, with patch monitors, home-based devices for continuous long-term ECG monitoring, this is going to become a larger and larger issue for a wide range of patients. And I think it's important that we address this issue now, determine what the best therapy is when the problem is still a relatively modest one, and before we are starting to deal with all sorts of patients from outside the pacemaker clinic.
All right, so there you have it. The ARTESiA trial really is going to be an important study to guide our therapy for years to come. We're going to literally be seeing millions of patients with subclinical atrial fibrillation, not just in device clinics, but also from other types of monitoring. And really, we don't know what to do about these patients. Anticoagulation is not an entirely benign therapy. Lifelong treatment definitely poses a risk. We really need to know how much these patients benefit. ARTESiA now has almost 1,000 patients enrolled. We need to keep enrolling these patients to finally get the answer to whether anticoagulation really benefits these patients. Thanks for listening this afternoon, and good luck enrolling patients.